Welcome to the deep dive. Imagine a disease that can live silently in your body for decades, often without a single warning, only to suddenly strike with devastating consequences, primarily affecting the heart. It's a disease many have never even heard of, yet it quietly impacts millions globally, and you might be surprised to learn it's even present in places like the US. Okay, let's unpack this. Today, we're embarking on a deep dive into the complex and often hidden world of American trypanosomiasis, better known as Chagas disease. Our mission is to pull back the curtain on this silent killer, unraveling the intricate journey of the microscopic parasite Trypanosoma cruzi and its primary vector, the stealthy triatamine or kissing bug. We're going to explore its microscopic origins, its fascinating and frankly terrifying life cycles, the surprising ways it can spread, the varied symptoms it causes in both humans and animals, the often challenging path to diagnosis, and what current treatments and prevention strategies look like. And of course, we'll dive into the cutting-edge research that's fighting back. This deep dive is custom tailored for you, our curious listener, to give you a truly comprehensive yet digestible understanding of this critical global health issue. To bring you this story, we've pulled together a rich stack of sources from the latest scientific reports and public health guidelines to intriguing historical accounts and vital research updates. So settle in as we guide you through a thorough and multifaceted exploration of Chagas disease. It's often called the silent killer, and that phrase really captures the insidious nature of Chagas disease. For so many people, it just flies under the radar for years, even decades.
Before making its presence known in the most devastating ways.
What's truly fascinating and deeply concerning is how the parasite's own life cycle allows it to evade immediate detection. Think of it like a master of disguise, quietly establishing itself in the body.
Right.
This silent progression is precisely what makes Chagas such a challenging public health issue. At its core, Chagas disease, or American trypanosomiasis, is a zoonotic disease.
Zoonotic meaning it jumps from animals to humans.
Exactly. It's an illness that can be transmitted from animals to humans. It's caused by this tiny organism called Trypanosoma cruzi, which is a hemoflagellate protozoan.
Okay, break that down. Hemoflagellate protozoan.
Right, so protozoan means single-celled parasite. Hemoflagellate means it can swim around in the blood hemo, and it has a little tail, a flagellum, for moving. It lives part of its life cycle there.
Got it.
It's part of a group of diseases often called neglected tropical diseases because they disproportionately affect vulnerable populations, primarily in Latin America. But as we'll see, its reach is definitely expanding. So it's a silent threat, primarily affecting vulnerable communities. And its history is surprisingly ancient. This wasn't just a modern discovery, was it?
Far from it. While its official discovery came in 1909 by the brilliant Brazilian physician Carlos Ribeiro Justiniano Chagas, who meticulously described the full life cycle of the parasite, which was quite a feat.
Absolutely.
The parasite itself has been around for millennia. Imagine this. Intriguing findings have revealed T. cruzi infection in Homo sapiens mummies from Chinchorro, Chile, dating back approximately 9,000 years.
9,000 years, wow.
Yeah. That tells us this disease was impacting ancient Amerindian populations in the Andean region long before recorded history. The parasite then slowly spread through human migrations across the American continent. There's even evidence suggesting it reached North America as early as 1150 BC.
Really? In North America that early?
For instance, parasite DNA was found in a male mummy from that era who exhibited megacolon, an abnormal enlargement of the colon, which is a classic severe symptom of chronic Chagas disease.
A hallmark symptom, right?
Exactly. And even as early as the 16th century, chroniclers reported the presence of the insect vectors, these triatamine bugs, in human dwellings. This shows a really long-standing and uncomfortable association between the bugs, humans, and the disease.
That's truly remarkable, a disease with such deep historical roots, evolving right alongside humanity. And a lot of research has naturally followed since Chagas' initial discovery, right? What were some of the biggest aha moments that came next?
Absolutely. The scientific community rallied. Herman Lent, who was actually a student of Carlos Chagas, dedicated his entire career to triatamine research, really advanced our understanding of these specific insect vectors.
Okay.
And one of the more intriguing historical footnotes is the medical speculation surrounding Charles Darwin himself.
Darwin, how does he fit in?
Well, many wonder if he might have been exposed to triatamines during his famous travels in Argentina, and if his subsequent long-term illness could be linked to Chagas disease.
Huh. Is there any evidence for that?
It's mostly speculation. The acute phase of Chagas usually involves a fever, which Darwin didn't mention in his journals. So a direct link for the acute stage seems less likely. But the question itself highlights just how pervasive and ancient this disease is, that it was even considered.
Let's talk about the sheer scale of this problem today. What's the global burden, and how is its epidemiology, how it spreads and affects populations changing in our modern world?
The statistics are, frankly, staggering. We're talking about approximately 6 to 7 million people affected worldwide. It's estimated to cause around 12,000 annual deaths.
12,000 deaths a year.
Yeah, and a massive 75 million people are at risk of infection. What's particularly alarming for public health is that only about 1 out of every 10 infected individuals is ever diagnosed.
Only 1 in 10. That's terrifying.
It really is. The disease is endemic, meaning it's regularly found in 21 countries across Latin America. Think Argentina, Belize, Bolivia, Brazil, Chile, Colombia, Costa Rica, Ecuador, El Salvador, French Guiana, Guatemala, Guyana, Honduras, Mexico, Nicaragua, Panama, Paraguay, Peru, Suriname, Venezuela, Uruguay. It's a huge swath of the continent.
But it's clearly no longer confined to just those regions, is it? We're seeing it pop up in unexpected places, changing its global footprint.
Precisely. We're witnessing a significant shift, largely driven by globalization. T. cruzi is now considered endemic in parts of the U.S., particularly in the southern states. Estimates suggest up to 10,000 individuals might be affected there.
10,000 in the U.S.?
And this expansion beyond its traditional borders is primarily driven by the migration of asymptomatic carriers, people infected with Chagas, but showing no symptoms from Latin American countries to non-endemic areas like Europe, Asia, Australia, New Zealand, and Canada.
Right, people travel. The disease travels.
Exactly. These imported infections mean the disease is truly globalizing, even in regions where the local insect vectors weren't initially present. Traditionally, Chagas disease was seen as a rural problem, strongly associated with poor housing conditions like mud walls and palm roofs, which are perfect hiding places for these bugs.
The classic image.
Right. However, we're now observing a progressive and concerning shift from rural to urban environments. This is due to several interconnected factors. There's the ongoing migration of people from rural to urban areas, seeking economic opportunities, of course. Then there's the adaptation of the insect vectors themselves to city peripheries due to things like deforestation and rapid urbanization. This creates what we call enzootic cycles.
Meaning cycles in animal populations.
Yes, involving synanthropic animals, those that live alongside humans like rats or raccoons and domestic mammals in these new urban habitats. And critically, there's been a rise in oral transmission as a dominant mechanism in urban settings. We'll get into that more. We're also seeing increased human-to-human transmissions in cities, such as vertical transmission mother to child, through blood transfusions, organ transplants, and, as we'll discuss, even the possibility of sexual transmission. All of these contribute to its urbanization.
That's a truly baffling paradox. So the bug is present, and the disease is considered endemic in parts of the U.S., but locally acquired human infections are still relatively uncommon. Here's where it gets really interesting. What's fundamentally different about the U.S. situation that prevents it from spreading like wildfire here?
That's a crucial distinction, and it comes down to a few key biological and ecological factors. Firstly, in the U.S., we generally lack a pervasive domestic cycle for the kissing bug.
Meaning they don't live in our houses as much?
Right. They don't permanently colonize human homes in the same way they do in some endemic rural areas of Latin America. They might wander in, but they don't set up shop, so to speak.
Right.
Secondly, many of the U.S. triatamine species have what we call delayed defecation habits. This is really important. For the parasite to be transmitted effectively, the bug needs to defecate on the host during or immediately after taking a blood meal.
So the parasite gets rubbed into the wound.
Exactly. If the bug waits too long to defecate, maybe crawls away first, the chance of transmission significantly decreases.
Ah, that makes sense.
And thirdly, there's just overall infrequent human contact with these bugs in the U.S. compared to high transmission regions. Our homes are generally better sealed, different building materials, different living habits. So while the potential is definitely there, these factors act as important natural barriers.
To truly understand Chagas, we have to get to know its main players. First, let's look at Trypanosoma cruzi itself, the master parasite. What makes this microscopic hemoflagellate protozoan such a formidable opponent?
Okay, so its identity as a hemoflagellate protozoan tells us it's single-celled, uses that flagellum tail to move, and spends part of its life in the blood. What makes it so formidable is its ability to change forms and hide.
Change forms.
Yeah. When it enters a vertebrate host, that's us, or an animal, the organisms circulate in the blood as trypomastigotes. Think of these as its traveling form, the ones with the tail,
Uh-huh.
but they don't multiply in the blood. Instead, they invade host cells, drop their flagellum, and transform into mastigotes. These are their hiding and multiplying forms, tucked away within various tissues like muscle or nerve cells.
So they hide inside our own cells to multiply.
Exactly. This ability to switch forms and hide inside cells is absolutely key to its persistence and its evasion of our immune system. What's truly remarkable and also makes control incredibly challenging is its incredibly wide host range. T. cruzi is thought to be capable of infecting animals in most, if not all, mammalian and marsupial orders.
Wow, most mammals and marsupials.
Yeah, there's virological or serological evidence, meaning evidence from viruses or blood tests of infections in over 150 different species.
Like what kind of animals?
Oh, common domestic animals like dogs and cats, of course.
Yeah.
Various livestock, pigs, sheep, goats, horses, even South American camelids like llamas. Wild animals like raccoons, opossums, coatis, skunks, various rodents like guinea pigs, bats, anteaters, armadillos, non-human primates.
It's a huge list.
It keeps going. Even exotic zoo animals like arid wolves, bears, red pandas, meerkats, hedgehogs, sugar gliders, and wallabies have been found infected.
So it's not just a threat to humans and common pets, but a huge swath of the animal kingdom. And I understand there are even new reports challenging old assumptions about what it can infect, pushing the boundaries.
That's right, and it complicates our understanding of its ecology quite a bit. In the past, birds, reptiles, and fish were generally considered refractory, meaning resistant, to infection with T. cruzi.
Okay, so they thought those were safe.
Pretty much. But new reports are challenging this. We now have PCR-positive lizards, snakes, and even an American barn owl. Plus, experimental transmission to the bugs from lizards has been documented.
Huh. So the picture is getting even more complex.
Definitely. It suggests the parasite's host range might be even broader than previously thought, highlighting the complex ecological web that exists within and making eradication efforts even more intricate.
And it's not a single uniform parasite either, is it? It has different flavors, so to speak, that affect its behavior, almost like different strains of a virus.
That brings us to its taxonomic complexity. You're exactly right. T. cruzi is actually divided into 6 main discrete typing units, or DTUs, labeled TCI through TCVI.
DTUs like different genetic groups.
Precisely. Think of them like different strains or versions of the parasite. They're all T. cruzi, but each DTU represents a genetically distinct lineage. These differences are based on detailed molecular analyses, and they reveal a high level of genetic diversity and even potential hybridization mixing between them.
And why do these DTUs matter? Do they behave differently?
Crucially, yes, these DTUs differ significantly in their geographic distribution, the range of hosts they prefer to infect, and perhaps most importantly for us, the clinical outcomes they tend to cause in infected individuals.
Can you give an example?
Sure. TCI is very widespread across the Americas and is often linked to chronic cardiomyopathy heart disease. TCII and TCV are more predominant in the southern cone of South America, like Brazil and Argentina, and are associated with particularly severe cardiac manifestations of Chagas disease. TCIV, on the other hand, has been specifically implicated in those oral transmission outbreaks we mentioned, particularly in the Amazon region.
So if I'm a patient, what's the one thing I really need to understand about these DTUs and how they might affect my diagnosis or treatment?
The most critical takeaway is that this genetic variability impacts everything from diagnosis to treatment. For instance, DTU variability can affect the sensitivity of serological tests, those blood tests for antibodies, potentially leading to false negative results, especially with certain DTUs like TCI or if hybrid forms are present.
So the test might miss it depending on the strain.
It's a possibility, yeah. And from a therapeutic perspective, the susceptibility of T. cruzi to our 2 main drugs, benznidazole and nifurtimox, also varies among DTUs. TCI strains, for example, often exhibit higher resistance compared to TCII and TCVI.
Right, so treatment might not work as well for certain strains.
Exactly. So understanding these flavors of T. cruzi is vital for developing more accurate diagnostics and potentially more targeted effective therapies in the future.
Now let's turn to the other main culprit, the triatomine insects, famously known as kissing bugs. What exactly are these creatures and where do they get their colorful and frankly unsettling names?
They're a truly fascinating, if problematic, group. These insects are commonly known as kissing bugs because they often bite around the mouths or face at night while people sleep.
Okay, that explains that one.
Yeah. Also assassin bugs, cone-nosed bugs because of their pointed heads, or sometimes vampire bugs because, well, they feed on blood. In Latin America, they go by many local names like barberos, vinchucas, pitos, chipos, and chinches. Scientifically, they all belong to the subfamily Triatomini, which is part of the larger family Reduvidae. There are over 130 species of triatamines that can transmit T. cruzi, though with varying efficiency. The most important genera groups of species for human health are Triatoma, Rhodnius, and Panstrongalus.
And are some worse than others?
Definitely. Among these, Triatoma infestans and Rhodnius prolixus are considered the most efficient and relevant vectors. This is due to their high tolerance for humans and their remarkable adaptability to living inside household, making them truly domestic pests in some regions. Other important species include T. dimidiata and P. magistus.
And what about here in the U.S.? Do we have them?
Oh yes. Even in the U.S., we have 11 native species of kissing bugs, and 9 of them have been found naturally infected with T. cruzi. 4 of these are particularly noteworthy because they commonly invade residences: Triatoma sanguisuga, T. kerstakeri, T. protracta, and T. rubida. So yes, they're more widespread than many people realize.
They truly are everywhere, lurking in the shadows. Tell us more about their life cycle. How do these bugs develop, and what are their behaviors that make them such effective vectors?
Triamines undergo what's called incomplete metamorphosis. Unlike, say, a butterfly, they don't have a pupal stage. Their life cycle progresses through 3 main stages: egg, 5 nymphal instars, and finally the adult stage where they develop wings.
Instars, like molting stages.
Exactly. Think of these instars as simply different growth stages, like a snake shedding its skin to grow larger. The nymphal development involves a progressive increase in size and blood feeding capacity through each of these 5 stages. The first instars are tiny and vulnerable, while the pre-adult 5th instars are much larger and develop functional wings and sexual organs before their final molt into adults.
And how long does this take?
The duration of these stages can vary significantly, depending on the species, the ambient temperature, and critically, the availability of blood meals. They need blood to grow and molt. As for their habits, they are primarily nocturnal, active at night. They prefer dark environments to hide during the day, cracks in walls, under mattresses, behind pictures, in cluttered areas.
So they hide well.
Very well. They feed mainly on the blood of humans, birds, or mammals, though there are some reports of certain species feeding on reptiles or amphibians. Adults achieve active dispersal by flight, usually around dusk and early evening. That's when they might fly into homes attracted by lights. The nymphs, lacking wings, have to crawl to find their blood meals, which makes them equally dangerous if they're already inside.
Now that we truly understand the culprits, let's break down how Chagas disease actually makes its way into a host. What's the primary and perhaps most infamous way this parasite spreads to humans?
The primary route, and certainly the one most people associate with Chagas, is vector-borne transmission. This is where the triatamine insect, our kissing bug, does its dirty work.
The bite and the poop.
Essentially, yes. It occurs when an infected bug takes a blood meal from a vertebrate host. After a period of maybe 2 to 4 weeks, during which the parasite develops and multiplies in the insect's gut, the bug releases infective metacyclic tripomastigodes in its feces. These are the parasite's infective stage, ready to invade a new host. Crucially, as we touched on, the most effective vector species tend to defecate on the host during or immediately after feeding. The parasites then enter the host's body through mucous membranes, eyes, mouth, or through breaks in the skin, including the bite wound itself.
And scratching makes it worse?
Definitely.
Yeah.
Often, the host scratching the itchy bite further aids in inoculating the parasites into their system. It's a remarkably efficient, if unsettling, mechanism.
If we connect this back to what we discussed earlier, it really helps explain why, despite the presence of infected kissing bugs in the U.S., vector-borne transmission to humans is actually quite rare here.
Exactly. It comes down to that combination of factors we mentioned. The U.S. species of triatamines are generally poor transmitters because many have those delayed defecation habits.
Right, they poop later.
If the bug waits too long to defecate after biting, the window for the parasites to be rubbed into the bite wound or mucous membranes significantly narrows. Plus, there's much less frequent human contact with these bugs compared to highly endemic areas, and critically, these species tend not to permanently colonize human homes. They often stay in what we call sylvatic, wild, or peridomestic, around homes like in doghouses or woodpiles, cycles, rather than true domestic ones inside the house.
So the bugs are around, but the stars don't align as often for transmission here.
That's a good way to put it. The conditions for efficient human transmission are largely absent in most U.S. settings.
Beyond the infamous bug bite, there's a growing concern about another major transmission pathway: oral transmission. How exactly does this happen, and what does it mean for disease control, especially in urban areas?
Oral transmission is indeed becoming a highly significant route, especially in some urban environments, and it completely bypasses the bug bite. Hosts can become infected by directly consuming infected triatomine insects.
Eating the bugs.
Yeah, maybe accidentally. This is particularly relevant for insectivores like raccoons and opossums, but it can also happen with domestic animals like dogs and cats. And even non-human primates may be eating contaminated food scraps. For humans, a more significant and increasingly common route is the ingestion of food or drink contaminated with T. cruzi. This isn't usually about undercooked meat. It's more often contaminated fruits, vegetables, or unpasteurized fruit juices. Things like acai pulp or sugarcane juice are classic examples.
Acai bowls. Seriously.
It's been implicated, yes, if the processing isn't careful. The juice or pulp can get contaminated if insects or their feces get mixed in during harvesting or processing. We've even seen outbreaks linked to contamination by secretions from opossum anal glands. Opossums can be reservoirs, and T. cruzi can replicate in those glands.
Oh, wow, okay.
What's particularly concerning is the parasite's viability in contaminated food. It can remain alive and infective for 6 to 72 hours at room temperature, and surprisingly, up to 16 days when refrigerated.
16 days in the fridge.
Yeah. This means the contamination doesn't have to be immediate or obvious. Something contaminated could sit for a while and still pose a risk.
So this isn't just about a bug bite in a rural dwelling anymore. This truly has changed the epidemiological landscape, particularly in cities, making it a much more complex public health challenge.
Absolutely. Oral transmission is now the most frequent cause of acute Chagas cases in countries like Venezuela, especially following major outbreaks in Caracas back in 2007. It's also a dominant mechanism in Brazil, Colombia, Bolivia, and Guyana. These outbreaks have very distinct characteristics that differentiate them from vector-borne cases. They often occur in groups affecting families, schools, or even restaurants, all linked by a common contaminated food source.
Ah, so multiple people get sick at once.
Exactly. And crucially, there are typically no visible signs of the parasite entering through the skin, like Romaña sign or a chagma. The parasitic load ingested is often considerably high in these cases because individuals might consume the parasite contents from one or more infected bugs, potentially hundreds of thousands of trypomastigotes.
Which leads to more severe illness.
Generally, yes. This leads to simultaneous symptoms within the group, often more severe illness requiring hospitalization, and unfortunately higher mortality rates, maybe around 5% if untreated. And notably, the transmission can occur at a significant distance from where the food was originally contaminated, adding another layer of complexity to tracking and prevention. Think about food supply chains.
Right, the contamination could happen far away from where people get sick.
Precisely.
In addition to vector-borne and oral routes, there are other crucial human-to-human and accidental transmission pathways. What are these, and why are they so important in our interconnected world?
Yes, these are critical, especially in non-endemic regions where vector transmission is minimal or absent. Blood transfusions are, in fact, the second most common mode of acquisition after vector transmission in many parts of America.
So contaminated blood supply.
It's a risk, yes. T. cruzi can survive for long periods in whole blood and blood products. That's why rigorous donor screening is essential, along with measures like leukocyte depletion, removing white blood cells, irradiation, and freezing, though freezing isn't fully protective. Organ transplants also pose a significant risk for donor-derived infections. Chagas should be strongly suspected in transplant patients who are from endemic areas and develop specific symptoms like fever, an enlarged liver, hepatomegaly, heart inflammation, myocarditis, or brain spinal cord inflammation, meningoencephalitis.
Okay, so screening donors is key there too.
Absolutely. Then there's mother-to-child, or congenital transmission, which is a global problem. On average, it occurs in about 5% of children born to chronically infected mothers in endemic areas, with Bolivia showing the highest frequency.
5%.
Yeah.
That's significant.
It is. And this route is particularly important in areas where vector transmission has been successfully controlled, like Uruguay, where it has actually become the primary mode of acquisition. Screening pregnant women is crucial because even though antiparasitic treatment is generally contraindicated during pregnancy.
Right, the drugs can be harmful to the baby.
Correct. But screening allows healthcare providers to be prepared for immediate infant testing and treatment right after birth if transplacental infection occurs. High parasite loads in the mother significantly increase the risk of severe fetal infection or even death.
This raises an important question. Is there solid evidence for sexual transmission of Chagas disease? It sounds like a new and concerning development.
Indeed, there's growing evidence supporting sexual transmission, though more research is definitely still needed to fully understand its significance in humans.
What kind of evidence?
Experimental animal studies, mainly in mice, have revealed the presence of T. cruzi amastigote nests those multiplying forms in the reproductive organs. And sexual transmission of parasites has been observed between infected and uninfected mice.
Okay, in mice. What about humans?
Well, parasite DNA has been found in the germline cells, sperm and egg cells, of infected human hosts and their descendants, which is suggestive. While not yet definitively proven as a major route in humans, this mode of transmission could potentially help explain the spread of Chagas in non-endemic areas of Africa, Asia, Europe, and Oceania, where traditional insect vectors are absent. There have also been human family outbreaks with acute Chagas symptoms that have hinted at this possibility. It's a serious area of ongoing investigation.
Definitely someone to watch.
And finally, we must consider occupational or accidental transmission. This includes accidental injection via needle stick injuries, which is a risk for healthcare workers, and even possible aerosol transmission in laboratory settings if infected materials are improperly handled, maybe splashed or something.
So lab safety is critical.
Absolutely. This highlights the need for strict biosafety standards and proper personal protective equipment for anyone handling potentially infected animals, carcasses, tissues, or T. cruzi cultures. Think veterinarians, hunters, cleaning game, and laboratory workers.
How long can the parasite actually remain viable outside of a host or vector, say in their feces or in human tissues, and what are the best ways to get rid of it?
Okay, so in triadenine feces, T. cruzi loses its ability to move and infect fairly quickly. Usually within maybe 30 minutes to 9 hours, it dries out, basically.
Okay, so not forever on surfaces.
Right. However, in human cells and tissues like those handled in a lab or involved in organ transplantation, the traveling form, the trypomastogotes, can survive for 24 hours at room temperature and at least 10 days when refrigerated at 4 degrees C.
10 days refrigerated. Wow.
Yeah, it underscores the need for careful handling and disinfection protocols. Speaking of disinfection, the good news is that T. cruzi is susceptible to common agents like 1% sodium hypochlorite, that's household bleach, 70% ethanol, which is rubbing alcohol, iodine alcohol solutions, disinfectants like Virkon, and sterilants like glutaraldehyde and formaldehyde.
So standard disinfectants work.
Generally, yes. And for food safety, heat treatment is very effective. Blanching acai fruit at 70 degrees, about 158 degrees air, for just 10 seconds, or pasteurizing juice at 82.5 degrees air, about 180 degrees air, for 1 minute, can effectively kill T. cruzi.
Now, let's explore how Chagas disease actually progresses once it's in a human host. It's often described in distinct phases, each with its own set of characteristics. Can you walk us through them from those silent early days to the devastating late stages?
Certainly. The disease typically unfolds in 3 main phases. The first is the acute phase, which usually lasts for about 2 months right after infection.
Okay, the initial stage.
Right. And for the vast majority of infected individuals, we're talking over 95%, this phase is either completely asymptomatic, meaning they have no symptoms at all, or it presents with very mild, non-specific symptoms that might easily be mistaken for a common flu.
So most people don't even know they've been infected.
Exactly. The incubation period, while the parasite multiplies, lasts about 72 hours. In that small minority of cases where initial signs do appear, less than 5%, these can be quite distinctive. They include a chagoma.
Which is?
It's a localized, painless, reddish, hardened bump or swelling on the skin at the site where the parasite entered, or you might see Romagn's sign.
Ah, yes, the swollen eye.
That's the one. It's a painless swelling of one, or occasionally both, eyelids, often accompanied by conjunctivitis, pink eye, and enlarged lymph nodes nearby. These visible signs, if they appear, typically last for 1 to 2 months. If systemic symptoms are present during the acute phase, they're often frustratingly nonspecific and flu-like. Think fever, extreme tiredness or prostration, headache, joint and muscle pain, loss of appetite, anorexia.
Sounds like a bad flu.
Pretty much. You might also see regional or generalized swollen lymph nodes, an enlarged liver and spleen, hepatosplenomegaly, and swelling or edema, sometimes localized to the face or lower extremities. That edema is particularly common in those foodborne outbreaks we talked about. Gastrointestinal signs like nausea, vomiting, diarrhea, and upper abdominal pain can also occur.
Are there any other rarer signs?
Yes, less frequently reported signs, though still possible, include jaundice, yellowing of the skin, bleeding issues like vomiting blood, hematemesis, or nosebleeds, epistaxis, coughing, a transient measles-like rash, morbilliform rash, and even convulsions or blood and semen, hematospermia.
It sounds like those foodborne outbreaks can be particularly aggressive and dangerous.
They absolutely can be. Foodborne outbreaks tend to cause more severe illnesses, often requiring hospitalization, with an increased risk for cardiac or central nervous system involvement. Mortality rates in some of these untreated outbreaks have been tragically reported to be as high as 33%,
33%. Wow.
emphasizing the urgency of rapid diagnosis and treatment in those situations. Overall mortality in acute cases across all transmission types is typically below 10%, often due to acute heart failure, meningitis, or encephalitis.
What about tests during this phase, like an EKG?
Good question. Electrocardiogram, or ECG, findings during the acute phase might show things like an abnormally fast heart rate, sinusal tachycardia, a first-degree AV blockage, a common heart rhythm problem, low-voltage QRS waves, or primary T-wave alterations. Chest X-rays may also reveal an enlarged cardiac silhouette, indicating the heart is already under stress even early on. Following the acute phase, most infected individuals, over two-thirds, enter the chronic asymptomatic or indeterminate phase.
Right, this is the long, silent part.
Exactly. This phase is the true embodiment of the silent killer, as it can last for 10 to 30 years, or even a lifetime for some people. During this extended period, individuals have absolutely no symptoms and no clinical evidence of organ damage. The infection is often detected purely by chance during routine medical screenings, maybe for a job or when donating blood.
And their life expectancy is normal during this time.
Reassuringly, yes, the life expectancy for these individuals is generally similar to that of uninfected people from the same region. And spontaneous clearance of the parasite, while rare, has been reported as possible in some cases.
But there's a hidden danger.
Yes, this phase carries a critical hidden risk. Immunosuppressed patients, think organ transplant recipients, people with HIV/AIDS, maybe those on certain cancer therapies, are vulnerable to a reactivation of T. cruzi replication. This can present subclinically or, more dangerously, flare up with acute symptoms, sometimes very severely.
And then after decades of silence for many, there's the truly devastating chronic clinical phase, where the silent killer finally reveals its hand. This is where the long-term, irreversible damage occurs.
Yes, this is where the disease becomes life-altering and potentially fatal. Approximately 20% to 35% of individuals who remain in the indeterminate phase will eventually develop detectable organ damage after 10 to 30 years. Some studies suggest a slightly lower proportion, maybe closer to 9%, developing cardiomyopathy over 10 years in certain groups like blood donors, but the risk is significant regardless.
And the heart is the main target.
The most prominent and life-threatening syndrome is Chagasic cardiomyopathy. This involves chronic inflammation of the heart muscle, myocarditis, leading to the heart muscle weakening and enlarging, cardiac dilatation, severe abnormal heart rhythms, arrhythmias, and ultimately congestive heart failure. Often it starts as right-sided heart failure but progresses.
What would tests show them?
Echocardiography, an ultrasound of the heart, typically reveals reduced movement of the ventricular wall, hypokinesis, and often blood clots forming inside the heart chambers, interventricular thrombi.
Blood clots. That sounds dangerous.
It is. A common and very serious complication, actually, is cerebral infarction, or stroke, caused by one of those blood clots dislodging from the left ventricle and traveling up to the brain. This condition affects both genders equally, typically manifesting between 30 and 50 years of age. Beyond the heart, the disease can cause what we call megasyndromes, affecting the digestive system.
Mega meaning enlarged.
Yes, esophageal and intestinal motility disorders, problems with how the muscles move food through the digestive tract, can progress to megaesophagus. This causes severe symptoms like dysphagia, difficulty and pain during swallowing, excessive salivation, regurgitation of undigested food, and chest pain.
Eating must become incredibly difficult.
Terribly so. Similarly, megacolon can develop, leading to severe and prolonged constipation, abdominal pain, and asymmetrical abdominal distension. Imagine the simple act of eating or using the bathroom becoming a daily painful struggle. Other reported complications, though perhaps rarer depending on the geographic region and maybe the parasite strain, include megagallbladder, gallstones, cholelithiasis, gastric ulcers or chronic gastritis, and lower urinary tract dysfunction leading to incontinence. Less commonly, neurological signs can also be reported, though these are rarer than cardiac or digestive issues.
And what do doctors see if they look after someone has passed away from chronic Chagas?
Post-mortem findings in chronic cases often reveal a greatly enlarged, flabby heart, severe myocarditis, and interestingly, evidence of destruction of even non-parasitized cells in the heart. In the digestive tract, you see thickening of the esophageal and colon walls, and crucially, the destruction lois of neurons within the nerve plexuses of these organs. That nerve damage is key to the megasyndromes.
So it's not just humans who suffer from this devastating disease. Animals also experience Chagas, and this broad impact makes it even harder to control. What does it look like in them?
You're absolutely right. The animal impact is crucial for understanding the whole picture, especially reservoirs. Clinical illness has mainly been observed in dogs and captive non-human primates. We also see sporadic cases in other species, including those exotic pets and zoo animals we mentioned, reinforcing that wide host range. An American black bear cub was even found infected in the wild.
What about dogs specifically? They're common reservoirs, right?
Yes, very important reservoirs, especially in paradomestic cycles. Experimentally infected dogs can develop acute myocarditis, arrhythmias, and sometimes sudden collapse and death. In naturally infected dogs, the early signs might be milder or nonspecific, maybe a feverish illness, lethargy, swollen lymph nodes, lymphadenopathy, enlarged liver, hepatomegaly, anemia, diarrhea, vomiting, edema, or weight loss.
And congenital infection. Can puppies get it?
Yes, congenitally infected puppies, those infected from their mother, can show persistent fever, weight loss, chronic diarrhea, and early signs of heart disease. The chronic stage in dogs is predominantly characterized by heart disease, including congestive heart failure, chronic myocarditis, cardiac dilatation, and arrhythmias, very similar to humans in many ways.
Any other signs in dogs?
Yeah.
Neurological?
Occasionally, yes.
Yeah.
Neurological signs like lameness, lack of coordination, ataxia, weakness or partial paralysis, paresis, full paralysis, incontinence, cranial nerve deficits, seizures, and even eye inflammation, choroiditis have been reported. Interestingly, though, unlike humans, megaesophagus and megacolon have generally not been reported in dogs.
Okay. What about primates?
Non-human primates in captivity usually present with few or no initial signs, though some reports mention nonspecific illness, anemia, hepatosplenomegaly, or cardiac involvement. A rare case of orchitis inflammation of the testicle was also noted in an acutely infected rhesus macaque. And critically, reactivation of T. cruzi has occurred in SIV co-infected macaques, similar to HIV in humans, highlighting that immunosuppression is a risk factor across species.
And cats. Less common.
Much rarer in terms of published cases, yes. Signs reported have included fever, edema, weight loss, and neurological symptoms like convulsions and paresis. However, a study in U.S. animal shelters found that seropositive cats, those with antibodies, were more likely to have mild to moderate cardiac inflammation when examined microscopically after death, suggesting a subclinical impact that might often go unnoticed.
And briefly, any other notable animal cases?
A few interesting ones. A horse developed hind limb lameness and ataxia with parasites found in a spinal lesion. Antibody tests suggested about 40% of horses tested had been exposed, indicating maybe many missed illnesses. A llama experienced severe bloody diarrhea, muscle atrophy, and progressive weakness, leading to paralysis on one side. Hedgehogs and sugar gliders have presented with sudden death. Sugar gliders sometimes show swelling around the eyes, with postmortem evidence of myocarditis and internal bleeding in the gut. Naturally infected rats also show cardiac lesions and arrhythmias. Cardiac conditions seem to be common across many captive wildlife species, often discovered after sudden deaths or stress events.
That's a huge range of impact. So what does this all mean for the body on a cellular and systemic level? Let's truly delve into the pathophysiology, the actual mechanisms of damage that T. cruzi inflicts.
Okay, the pathogenesis of Chagas disease is incredibly complex. It involves a dynamic interplay between the parasite's persistent presence and the host's intricate and sometimes counterproductive immune responses. Remember, the mastigotes are the multiplying forms that replicate intracellularly within various host tissues.
Hiding inside cells.
Exactly. While the trypomastigotes, the traveling forms with the tail, circulate briefly in the bloodstream before invading new cells. This ability of a mastigotes to hide and multiply inside our cells allows them to largely evade the host's immediate immune surveillance, making the infection so persistent. The immune system interacts with the parasite in fascinating and sometimes detrimental ways. Those initial inflammatory reactions, like the Chagoma or Romaña sign, are visible indicators of the body's first local response trying to contain the invasion.
How does the parasite actually get into the cells?
It's clever. T. cruzi trypomastigotes utilize specific receptors on our cells, like ATP receptors. Then specific signaling pathways inside the cell, involving things like cyclic AMP, CMP, and calcium, Ca2+ levels, are manipulated by the parasite to allow it to enter. The fusion of lysosomes, which are normally like the cell's recycling centers with the parasite-containing vacuole, is also critical for the parasite's invasion and for the retention of mastigotes, allowing them to replicate undisturbed within that protected space.
And it can get into muscle cells easily.
Yes, crucially, the parasite efficiently penetrates non-phagocytic cells, like muscle cells and nerve cells, quite quickly. Once inside, it becomes inaccessible to many components in our blood, like serum lytic factors, which are designed to destroy foreign invaders.
So the immune system tries to fight back, but the parasite hides.
It tries, yes. While T. cruzi has mechanisms to escape immune detection, there's evidence of a role for humoral immunity that's antibody-based responses. Protective antibodies seem to be primarily of the IgG2 subclass, suggesting this type is important in controlling the initial acute infection. B. Lymphocytes, the cells that make antibodies, are also involved in susceptibility.
But antibodies aren't enough.
Not usually on their own for a cure, no. It's cellular immunity, particularly thymus-dependent cellular immunity, that is considered crucial for control. Specific immune cells called CD4 plus and CD8 plus T cells that produce a signaling molecule called gamma interferon, IFN, play a central role in fighting the infection.
But the parasite fights back against T cells, too.
It seems so. The parasite can cleverly subvert host cell silation, a process involving sugars on cell surfaces, which can compromise the effectiveness of the CD8 plus T cell response. Despite these challenges, immunodominant memory T cells are present in both acute and chronic stages, indicating our bodies are mounting a response, but it's often not enough to eliminate the parasite completely.
I understand there's a big debate about whether autoimmunity plays a role here. Can you shed some light on that? Because it sounds like our own body might turn against itself.
That's a key and complex area of research, and honestly, it's still debated. One school of thought suggests that autoimmunity can be triggered early, in the acute phase. This theory proposes that tissue damage could result directly from T. cruzi activity or from cross-anti-self reactions.
Meaning the immune system gets confused.
Exactly. Where our immune system mistakenly attacks healthy host tissues because some parasite antigens look very similar to our own body's molecules, a phenomenon called molecular mimicry.
Okay, that's one theory. What's the other?
Another perspective suggests that autoimmunity unfolds later, perhaps only becoming significant in the chronic phase, or maybe it remains subclinical until then. In this view, chronic inflammation and potentially mechanisms like antibody-dependent cytotoxicity, where antibodies tag host cells for destruction, and the direct activation of autoreactive T cells that attack self, become the main drivers of autoimmune pathology.
So direct damage versus mistaken identity, or maybe both?
It's likely a combination, honestly. A complex interplay between direct parasite-mediated damage and an overzealous or misdirected immune response that contributes to the chronic tissue injury, especially in the heart and gut. Molecular insights further complicate our understanding. We can detect the nuclear DNA and DNA of T. cruzi in the tissues of chronic Chagas patients using sensitive tests like PCR, confirming this cryptic parasite persistence even when no active parasites are visible under a microscope.
So the parasite is still there, genetically speaking.
Yes, and even more fascinating, research in rabbit models has shown that T. cruzi kDNA, its mitochondrial DNA, which is a separate little circle of DNA, can actually integrate into the host's genome.
Into our DNA?
Into the host DNA, yes. This integration could potentially drive mutations, perhaps contributing to the variable clinical manifestations and the specific pathogenesis we see in the disease. It adds another layer of complexity to how the damage might occur over time.
And what about the specific damage to organs like the heart and digestive system that we discussed earlier? How does the parasite cause that specific kind of damage?
In the heart, the chronic inflammation leads directly to myocarditis and that characteristic heart enlargement. Microscopically, you see changes like an abnormal increase in cells lining the small blood vessels, endothelial proliferation, and thickening of the basement membrane supporting those vessels. However, it's important to note that occlusive lesions in the main coronary arteries, the kind that cause typical heart attacks from blocked arteries, are generally not a feature of Chagas heart disease. It's more of a diffuse inflammation and damage.
And the megasyndrome's in the gut.
For the digestive system, the development of megaesophagus and megacolon is primarily attributed to significant neuron loss and neuritis inflammation and destruction of nerve tissue, affecting the intricate network of nerves, the enteric nervous system, that controls bowel motility. This severe neuronal damage disrupts the normal signaling needed for muscle contraction and relaxation, leading to the profound motility disorders and dysfunction we see in these megasyndromes. The nerves simply can't tell the muscles what to do properly anymore.
You mentioned earlier that birds were once thought to be completely resistant to T. cruzi. Is there a known reason for their refractoriness, and what does that mean for how the disease might spread?
Yes, birds are largely refractory or resistant to T. cruzi infections. This seems to be due to a combination of innate immune factors they possess and potentially the lytic effect of the chicken complement system, a specific part of their blood-based immune system that can directly destroy the parasite.
So their bodies just kill it off quickly.
It seems so. This innate immune mechanism appears to efficiently eliminate the infection, meaning that hatched chicks are typically parasite-free. However, and this is vital, the presence of chicken blood in the insect gut does not inhibit T. cruzi growth within the triatomine bug.
Ah, so the bug can still get infected from a bird meal, even if the bird isn't sick.
No, the bird doesn't get infected to pass it on, but if the bug is already infected, feeding on a bird doesn't kill the parasite inside the bug.
Got it. So an infected bug feeding on birds can still later bite and infect a human.
Exactly. It means that infected triatomine bugs feeding on birds can still successfully develop the parasite internally and then later transmit T. cruzi to humans or other mammals. This underscores the ongoing risk even in environments where birds are common. In fact, the coexistence of birds and triatomines can sometimes favor Chagas disease endemicity by providing a consistent, readily available blood meal source for the bugs, allowing bug populations to thrive, even if the birds themselves aren't acting as amplifying reservoirs for human infection.
Given the silent nature of Chagas disease, detecting it can be incredibly challenging. How do clinicians go about diagnosing active infections, especially early on, and then those chronic, often symptom-free cases in both humans and animals?
Diagnosing Chagas disease really depends critically on the phase of the infection. For acute or reactivated infections in both humans and animals, the goal is to directly detect the parasite itself when it's actively circulating or replicating.
How do you do that? Look under a microscope.
That's one way, yes, microscopy.
Yeah.
Simply observing the trypomastogotes, those actively moving traveling forms in fresh blood smears, or finding amastogotes the stationary, multiplying forms in stained tissue samples if a biopsy is done. Concentration techniques like examining the buffy coat, a layer of white blood cells separated from spun blood, or using the Strout method can increase the chances of finding the organism if it's present in low numbers in the blood. Molecular tests, particularly PCR, polymerase chain reaction, are also very useful here. They identify T. cruzi DNA directly in clinical samples like blood.
So they look for the parasite's genetic material.
Exactly. PCR is especially valuable for showing rising levels of parasite DNA during those reactivated infections in immunosuppressed patients. Though it's worth noting, occasional positive PCR tests can also be seen in otherwise healthy, asymptomatic individuals during the indeterminate or chronic stage, reflecting that cryptic persistence of the parasite we discussed.
Any pitfalls with PCR?
A crucial caution is that some PCR tests can accidentally amplify DNA from other non-pathogenic trypanosomes like T. randalli or T. dionysi, which sometimes co-infect people or bugs in the same regions. This could lead to false positives if the test isn't specific enough or if results aren't interpreted carefully. Loop-mediated isothermal amplification, LAMP tests, are also available for humans now, offering a potentially simpler, faster alternative to traditional PCR, which might be useful in lower resource settings. Other less common methods include in situ hybridization, used in one primate case, and parasite culture from blood or tissue, though culture can be slow and insensitive.
What about that old method, xenodiagnosis?
Ah, yes. Historically, xenodiagnosis was considered highly accurate in South America. It involves feeding laboratory-reared, T. cruzi-free triatomines on the suspected patient and then examining the bug's gut contents for parasites weeks later.
Using bugs to diagnose.
Wow, yeah, it's quite something. But it's cumbersome, slow, and has largely been superseded by more modern and sensitive tests like PCR now. Now, for chronic infections in humans, the parasite is usually present in such extremely low numbers in the blood that directly detecting it via microscopy or even PCR becomes very difficult and often yields negative results.
So how do you diagnose it then?
Therefore, serology is the most common and practical method for chronic cases. This involves detecting specific IgG antibodies that the person's immune system has produced against T. cruzi antigens. These antibodies persist for life, usually.
So you look for the immune response, not the parasite itself.
Exactly. But because of the potential for false positives with any single test, it's generally recommended, and often required, that two different serological diagnostic methods confirm a positive result. Using two different tests, maybe based on different antigens or different formats like ELISA and IFA, provides much higher confidence in the diagnosis.
Diagnosis is one thing, but proactive screening is another. Why is it so critical to screen for Chagas disease, especially in certain populations? And who are the key target groups we should be looking at?
Screening is profoundly important for several reasons that directly impact public health and individual well-being. Firstly, and critically, it allows us to prevent vertical transmission that mother-to-child spread. If you identify an infected woman before or during pregnancy, you can prepare to test and treat the baby immediately after birth.
Okay, preventing spread to the next generation.
Precisely. Secondly, early detection through screening enables treatment, particularly in younger people, which can potentially prevent or slow down disease progression to the chronic symptomatic stages. Thirdly, for those who might already have early signs of cardiac involvement, screening ensures they get appropriate cardiac monitoring and treatment, and it can significantly modify their risk for serious complications like stroke and sudden cardiac death.
So who specifically should be screened?
The target populations are quite specific based on risk factors. They generally include children under 18 born to infected mothers or with exposure history because they generally have lower rates of adverse effects from the medication and much better treatment outcomes if treated early.
Treat the kids early. Makes sense.
Women of childbearing age, especially those from or with mothers from endemic areas, are also a crucial group to screen to prevent congenital transmission in future pregnancies. Any adults aged 50 or younger who've lived in continental Latin America for 6 months or more are also recommended for screening due to their potential exposure risk.
What about blood donors?
Yes. Blood and organ donors are universally screened in many countries now, including the U.S., to prevent transmission through transfusions or transplants. And, of course, individuals who test positive for T. cruzi during routine blood screening, or those who have lived extensively in endemic countries outside the U.S., should definitely undergo confirmatory testing and evaluation.
And what does this screening process typically involve from that initial test to a confirmed diagnosis?
The typical process involves an initial screening test, often a commercial ELISA, enzyme-linked immunosorbent assay, which detects those T. cruzi antibodies. If that screening test is positive, a confirmatory diagnostic test is then required. This is usually a second, different type of serological test, perhaps another ELISA using different antigens or an immunofluorescence assay, IFA, often performed by a state public health lab or a reference lab.
So always 2 tests for confirmation.
Yes, that's the standard recommendation for diagnosing chronic infection. Historically, the CDC would perform confirmatory testing if initial results were discordant, but now state labs like the Wadsworth Center in New York handle much of this. This multi-step process is crucial for accuracy, given the lifelong implications of a positive diagnosis.
We've seen some impressive real-world examples of screening programs taking hold, even in non-endemic areas like the U.S. Can you share some of those successes and what they entail? Because they really offer hope.
Absolutely. These programs are vital beacons of hope and provide excellent models for broader implementation. The Strong Heart Screening Program at East Boston Neighborhood Health Center is a great example. It operates on 3 key pillars: educating healthcare providers in high-risk communities about Chagas, systematically screening and offering treatment where appropriate, and providing crucial community-based social support throughout the process.
What were the results like?
Pretty impressive. From March 2017 to May 2023, they screened over 14,000 patients, finding a Chagas prevalence of about 0.7%, with prevalence naturally increasing with age, as you'd expect for a chronic infection. Their data on the continuum of care is really insightful, though. Out of 102 positive screens, almost all had confirmatory tests sent, which were positive. A good number, 83%, completed an initial infectious disease appointment. But critically, only 30% completed the full 60-day course of treatment.
Only 30% finished treatment. Why so low?
It highlights the significant challenges even after diagnosis: side effects, cost, access, follow-up complexity. We'll get into that.
Okay. Any other programs?
Yes, Sun River Health in Brentwood, New York, launched a pilot program with a very smart focus. Obstetric patients from Chagas endemic areas, places like El Salvador, Honduras, Ecuador, Colombia, they astutely identified pregnant women as a captured audience.
Meaning they're already in the healthcare system regularly.
Exactly. They have regular prenatal visits, often have health insurance during pregnancy, and are generally easier to track. The rationale here is profound. Treating young mothers after pregnancy, since treatment is contraindicated during, can interrupt transmission to future pregnancies, allow for early diagnosis and treatment of infected babies, and facilitate testing of other potentially infected family members, thereby breaking cycles of transmission.
How did they implement it?
They simply added the T. cruzi antibody test to their standard prenatal blood panel, sending positive screens to a commercial lab, then confirmatory blood to the NYS lab, Wadsworth. To date, since September 2023, they've screened nearly 800 prenatal patients with 6 positive screens and 3 confirmed positives, all women originally from El Salvador. They also have a specific clear infant testing protocol, which is crucial. Chagas PCR testing at birth or 4-6 weeks, followed by serology at 9-12 months if earlier tests were negative.
That sounds very systematic.
It is, and similar efforts are happening elsewhere. The NYC Health Plus Hospital's Elmhurst Obstetrics Clinic has a similar prenatal screening program with detailed protocols for both mother and infant testing, including cord blood PCR. A key learning from a study that informed this program was finding a high percentage of at-risk patients with non-ischemic cardiomyopathy, heart muscle disease, not caused by blocked arteries, potentially Chagas-related, were unrecognized by their primary providers, really emphasizing the value of proactive screening in cardiology settings, too.
Are new programs still starting up?
Yes. For example, the Glencoe Family Medicine Clinic at Northwell Glencoe Hospital in New York is in its early stages, having started screening prenatal patients in October 2024. They've thoughtfully integrated simply asking for the patient's country of origin during prenatal visits, which is a simple yet effective first step for identifying potentially at-risk individuals. Their clinic structure is also helpful, with on-site lab testing and cardiac evaluations available to streamline the process. And finally, the NYC Health Plus Hospital's Bellevue and Metropolitan Cardiology clinics are also starting to implement Chagas screening. Their initial focus is slightly different, screening cardiac patients who are from endemic areas and already have diagnosed heart disease, like cardiomyopathy or arrhythmias. The aim here is twofold. One, to identify if Chagas is the underlying cause, which might influence treatment, and two, to use that patient as an entry point to test their family members, potentially identifying asymptomatic carriers.
This raises an important question. With all these promising programs, what are the major barriers that these programs, doctors, and patients still face in getting screened and, crucially, getting treated? It sounds like that 30% treatment completion rate is a big red flag.
There are significant hurdles, unfortunately, that prevent widespread success and contribute to numbers like that. A major one is still the lack of physician awareness or knowledge about Chagas disease, its prevalence even in places like the U.S., and who to screen. Many doctors simply don't think to test for it, or they might think it's too rare.
They just don't have it on their radar.
Exactly. There are also limited or sometimes confusing guidelines on precisely who and how to screen, and definitely confusion about which tests to order and how to interpret them, requiring both a screening and a confirmatory test adds complexity. The diagnostic process itself can be cumbersome, involving specialized specimen handling sometimes, potential staff turnover in clinics or labs losing track, and the reliance on state or reference labs for confirmatory results, which can introduce delays. Patient barriers are also substantial. Many patients have limited knowledge of the disease itself, why testing is important, or what positive result means. They may struggle to take time off work for multiple appointments, arrange childcare, or find transportation, especially for evaluation and the long treatment course.
And the healthcare system barriers.
Big ones there, too. Specialty referral challenges and costs for infectious disease and cardiology consultations can be prohibitive. Simply accessing necessary tests like echocardiograms can be difficult, depending on insurance or location. And lastly, the treatment itself is inherently complex. Just accessing the medication, which often has to be obtained through special programs or the CDC historically, can be difficult. Managing the intensive follow-up required due to the high rate of potentially severe side effects demands significant patient commitment and robust medical support. Finding alternative medications if the first isn't tolerated is basically impossible right now. And finally, the ongoing difficulty in tracking positive cases and ensuring their family members are also tested and linked to care creates huge gaps in controlling the spread. These are all interconnected challenges that make the fight against Chagas so difficult on the ground.
Once Chagas is diagnosed, especially in its early stages or for congenital cases, what are the current treatment options available? And what should patients know about them, particularly when it comes to managing potential side effects, which sound like a major issue?
Currently, benznidazole and nifurtimox, which is known by its brand name Lampet, are the only two drugs approved and used for treating human Chagas disease. They are primarily effective, or most effective, let's say, during the acute phase, and for congenital cases treating babies infected at birth.
How do they actually work against the parasite?
They have slightly different mechanisms. Benznidazole is thought to work by damaging the parasite's DNA, particularly its mitochondrial DNA, essentially disrupting its energy production and replication. Nifurtimox, on the other hand, seems to induce oxidative stress within the parasite, creating harmful reactive oxygen molecules that inhibit parasite growth and survival. While these drugs offer the best results in the early stages, especially in newly infected children and younger adults, where cure rates can be quite high, it's really important to understand they do not always completely clear the organism from the body, even when administered during the acute stage.
So they don't always guarantee a cure.
No, unfortunately not always. And in chronically infected patients, those who have been infected for years or decades, these drugs have generally shown little or no effect in substantially altering the long-term course of the established organ damage, like advanced cardiomyopathy or mega syndromes. Though some studies have suggested possible histological improvement in heart tissue or perhaps slightly longer survival times in treated chronic patients, the benefit is much less clear and often considered marginal compared to the risks and side effects.
What about the dosing and, crucially, the potential side effects? You mentioned they can be quite challenging for patients to tolerate.
You're right, that's a major challenge impacting treatment adherence and completion. For benznidazole, the typical dosing for adults is 5 milligrams per kilogram of body weight per day, usually divided into 2 doses for a duration of 60 days. Children usually receive a slightly higher weight-based dose, maybe 5-8 milligrams per day, again for 60 days, with a maximum daily dose usually around 300 milligrams.
60 days? That's a long time if you're having side effects.
It is. And interestingly, experimental dosing protocols in animal models involving things like prolonged treatment, intermittent dosing, or even higher doses have sometimes shown promise for better efficacy, suggesting there might still be room for optimizing how we use these drugs, but the standard remains 60 days for now.
Okay, here's where it gets really interesting. The side effects. Both drugs, unfortunately, come with significant side effects that can make patient adherence very difficult, and this is a huge barrier to successful treatment. What kind of things happen?
It's a major issue. For benznidazole, common side effects include dermatitis, which can range from mild to a very severe debilitating skin rash. Also, peripheral neuropathy, characterized by pins and needles, sensations, numbness, or pain, usually in the hands and feet. Gastrointestinal issues like abdominal pain, nausea, and a loss of appetite are frequent. Muscle pain, myalgia, joint pain, arthralgia can occur. Less commonly, but more seriously, it can cause reduced blood cell counts, cytopenias like low white cells or platelets, or liver inflammation, hepatitis. Headaches, a metallic taste, and general stomach upset are also reported.
That's quite a list. Is nifurtimox better or worse?
Nifurtimox tends to have an even higher incidence of side effects, and they can sometimes be more severe, particularly neurological ones. These can include seizures, tremors, nerve pain, muscle weakness. Gastrointestinal issues like decreased appetite, nausea, and vomiting are very common. Headaches and dizziness are also frequent. Skin reactions like rash or itchiness occur. And perhaps uniquely troubling, it can cause psychological effects like sadness, anxiety, or increased nervousness and insomnia.
Wow, that sounds really tough to get through.
It absolutely can be, which is why that treatment completion rate we mentioned is often so low. It's also vital to note that both drugs are contraindicated during pregnancy due to potential risks of birth defects or harm to the fetus. Therefore, treating women before they become pregnant is strongly recommended to reduce the risk of congenital transmission.
How do doctors manage these side effects if someone needs treatment?
Managing these adverse effects is key to improving adherence. Strategies often involve using antihistamines or topical oral steroids for skin rashes, prescribing medications for nausea, recommending taking the drugs with food. Sometimes a temporary drug holiday, pausing the medication for a short period, might be needed, or even dose de-escalation, reducing the dose to see if it becomes more tolerable. But all of this requires very close medical supervision and frequent follow-up visits, adding to the burden of care.
So treatment is tough, with significant hurdles. This makes prevention even more critical. What are the main strategies for breaking the cycle of Chagas disease transmission?
Prevention focuses heavily on vector control, especially in endemic areas where the kissing bugs thrive in and around homes. Housing improvement is fundamental. This means things like sealing cracks and openings in traditional adobe walls and thatched roofs, replacing thatched roofs with more durable materials like corrugated metal sheets, and installing window and door screens to physically block bugs from entering.
Better housing, fewer bugs.
Essentially, yes. Regular insecticide application is also crucial. This involves spraying residual action insecticides inside homes and on exterior walls, ceilings, and potential hiding places like cracks and crevices.
What kind of insecticides?
Products like pyrethroids, for example, beltamethrin, permethrin, or sometimes organophosphates, like malathion, are used because they can remain effective on surfaces for weeks or even months, killing bugs that land or crawl there. In some situations with heavy infestations, complete fumigation might be used for larger areas. Household cleanliness also plays a big role. Simple things like plastering dirt floors, removing accumulated clutter like wood piles or trash from around the house, and maintaining clean yards and animal corrals help minimize potential breeding and hiding sites for the bugs. The active involvement of women in implementing these household-level efforts in rural communities is often highlighted as essential for sustained vector control.
What about personal protection? Repellents.
Yes, personal protective measures can help. Using insect repellents containing DT or picaridin on exposed skin, especially at night, can deter bugs. Some essential oils like eucalyptus, neem, cinnamon, and citronella might also offer some limited repellency. Bed nets, particularly insecticide-treated ones, can provide protection while sleeping, although kissing bugs don't always behave like mosquitoes. They might crawl rather than fly directly to the net. Homemade UV or CO2-emitting light traps, using simple things like yeast and sugar in a bottle to produce CO2, can also be used sometimes to attract and capture triatamines, helping to monitor their presence and maybe reduce the local population slightly.
And what about heat or cold? You mentioned that for food safety. Does it help with vector control?
Thermal control is relevant. Triatamine bugs are sensitive to extreme temperatures. For example, T. infestans tolerates temperatures down to freezing, 0 degrees C, 32 degrees F, while R. prolixus may be down to 5 degrees C, 41 degrees F, but both are sensitive to heat above 50 degrees C, 122 degrees F. While maybe not practical for large-scale house disinfestation, this principle is directly applied in food safety for preventing oral transmission, like the blanching or pasteurization temperatures we discussed for acai or juice. Managing animal reservoirs is also incredibly important, especially in paradomestic settings. For example, testing breeding female dogs in kennels located in endemic areas can help reduce congenital transmission to puppies. Some research has looked at early prophylactic treatment of puppies in high-exposure kennels, though this raises concerns about promoting drug resistance if not done carefully. A simple measure is excluding domestic animals like dogs and cats from sleeping inside human bedrooms.
And what about some of the more cutting-edge or research-based approaches like biological control, where we use other living organisms to fight the bugs? That sounds like sci-fi.
Research into biological control is indeed expanding, and it's a fascinating area, though mostly still experimental for Chagas vectors. It involves using natural enemies or pathogens of the triatamines to reduce their populations.
Like what? Fungus.
Exactly. For example, entomopathogenic fungi like Metarhizium anisopliae and Ixora javanica have shown they can kill nymphal stages of triatamines in laboratory settings. Entomopathogenic nematodes, tiny worms like Heterohebditis and Steinernema, along with bacteria they carry like Photohabdus luminescens, have also demonstrated the ability to kill key vector species like T. infestans and R. prolixus. Heterohebditis indica shows promise specifically against T. dimidiata.
Viruses too.
Yes, viruses like the triatoma virus, TRV, have been found to naturally infect and induce high mortality in T. infestans populations, which is promising for potential biological control strategies. Endosymbionts, particularly those nematode-associated bacteria, can release toxins that cause high mortality in the vectors. And finally, parasitoids. These are usually tiny wasps or flies, like Telenomus farii, which lay their eggs inside the triatamine eggs or nymphs, eventually killing the host, are also being explored. It's like using nature's own targeted weapons against the bugs.
Fascinating. So beyond vector control, what are the other key prevention pillars?
Well, food safety is paramount for preventing that oral transmission route. This means thoroughly washing fruits and vegetables, practicing good hygiene like meticulous hand washing before food preparation, and carefully protecting all foods from potential contamination by insects, their feces, or reservoir animals like opossums. Cooking meats thoroughly and pasteurizing juices or other processed foods are also key. For blood and organ safety, as we discussed, rigorous donor screening using those sensitive serological tests is critical, along with measures like leukocyte depletion, irradiation, or freezing of blood products where appropriate, to significantly reduce transfusion-related transmission risk. Congenital prevention is huge. As mentioned, treating infected women before they intend to become pregnant appears to significantly reduce the risk of congenital infection in their future children. And for infants born to mothers known to be infected, prompt testing and treatment if necessary is the standard of care to prevent lifelong infection. Lastly, general disinfection protocols remain important in healthcare and lab settings, using those standard disinfectants like bleach, alcohol, or Virkon that are known to be effective against T. cruzi.
Looking ahead, what's on the horizon in terms of research and future directions in the fight against Chagas disease? Where are scientists focusing their efforts for new solutions, especially better treatments?
The fight is very much ongoing, and there are significant and promising research efforts underway. The Drugs for Neglected Diseases Initiative, DNDi, and its partners are actively working to discover and develop entirely new medicines. The ultimate goal is to find treatments that are safer, require shorter treatment courses, and are more effective, especially against the chronic stage, than our current options, benznidazole and ifurdamox.
What kind of new drugs are they looking at?
A key area is optimizing a new generation of T-Cruise inhibitors. For instance, there's a lot of work on compounds derived from the University of Washington series. These have novel modes of action, targeting different parasite pathways, and show promising efficacy profiles in early studies. The hope is that these could potentially lead to a single compound cure for Chagas disease, which would be a true game changer. There are also several other hit-to-lead projects underway where researchers screen large libraries of chemicals from natural and synthetic origins to find new starting points, hits, and then chemically modify them to improve their potency and safety, turning them into leads for potential drug development. Several promising new chemical series are currently progressing through this pipeline. Research into fexinidazole, a drug already used for sleeping sickness, is also showing some promise for Chagas.
Now, what about a vaccine? Is that a realistic long-term goal for humans or even animals, given the complexity of the parasite and how it hides?
Vaccine development is indeed a major long-term goal, but it faces several significant challenges, which is why we don't have one yet. The parasite's complex life cycle, with its different stages, are still incomplete understanding of the exact protective immunity mechanisms required to fully clear the infection, and a lack of perfectly predictive animal models all contribute to the difficulty.
And maybe lack of funding.
That too. Furthermore, there's often limited commercial interest from major pharmaceutical companies because the disease primarily affects marginalized populations in lower-income countries, which unfortunately reduces investment in vaccine R&D compared to diseases affecting wealthier nations.
What would an ideal vaccine look like?
Ideally, an effective vaccine would need to target antigens, those specific molecules the immune system recognizes that are expressed in all T. cruzi stages and across all the different DTU strains. These targets should also be highly conserved, not varying much between strains, and be crucial for the pathogen's survival or virulence. The cruzapine enzyme, which the parasite needs, is one example of a target that's been extensively studied.
What about animal models for testing?
Animal models are used, but have limitations. Mice offer partial immunity but don't fully replicate the chronic disease seen in humans. Dogs are actually considered better models because their disease evolution, particularly the heart disease, is more similar to humans. This makes dogs strong candidates for evaluating potential vaccines, including those based on recombinant proteins or DNA-based formulations. Rhesus macaques are also used sometimes.
Are there vaccines for dogs being developed? Since there are reservoirs.
Yes, research also aims specifically at canine vaccines, not just to protect the dogs, but potentially to help control transmission to humans, as dogs are key paradomestic reservoirs in many areas. Trials, for instance, in Argentina have shown some experimental vaccines can reduce natural infection rates in dogs, and DNA vaccines showed moderate protection against developing cardiac damage. However, no vaccine tested so far has completely prevented infection, and the protection achieved has generally been mild to moderate. So we're still some way off a highly effective vaccine, even for dogs.
What's fascinating here is a new, innovative approach that combines existing drugs with vaccine antigens, almost a 1-2 punch against the parasite. Tell us about that.
This is a really promising strategy called vaccine-linked chemotherapy, or sometimes chemoimmunotherapy. The idea is to combine antiparasitic drugs, like benznidazole, with vaccine antigens to achieve multiple synergistic benefits.
How does that work?
It aims to not only reduce the parasite load using the drug, but also simultaneously enhance the host's own specific immune responses using the vaccine components. A potential major benefit is that this combined approach might allow for a reduction in the dosage or duration of the antiparasitic drug needed.
Which could minimize those awful side effects.
Exactly. Minimizing side effects could dramatically improve treatment adherence and completion rates. Plus, the enhanced immune response might lead to better long-term control or clearance of the parasite, and potentially even improve overall cardiac and liver health outcomes compared to drug treatment alone.
Has this been tested?
Yes, it's been tested in animal models. For example, combining recombinant protein vaccines, like TC24C4 with a TLR4 adjuvant, or TS with an ISPA adjuvant, together with benznidazole in both acute and chronic mouse infection models, has shown encouraging results, reduced parasite burden in tissues, less cardiac inflammation, and fewer arrhythmias compared to either treatment alone. It's about getting more mileage out of existing treatments while actively strengthening the body's own specific defenses. Finally, in terms of diagnostics, there's work on improving how we monitor treatment success. An experimental diagnostic test called the multi-cruci assay is reportedly at an advanced stage of development. This aims to be a simpler test that can monitor disease progression and critically measure a patient's response to treatment. How would it do that? By measuring reductions in the levels of specific serum antibodies over time. A significant drop in antibody levels could serve as an indicator of parasitological cure, something that's currently very difficult to confirm. The potential for this kind of test to be used in decentralized healthcare settings, maybe even in remote areas, could revolutionize how we track treatment effectiveness and manage patients long-term. Hashtag outro.
We've covered a tremendous amount in this deep dive into Chagas disease, truly unmasking this silent killer. We've explored the intricate biology of Trypanosoma cruzi and its infamous kissing bug vectors, the multifaceted ways it spreads from bug bites to contaminated food to mother to child, and its varied and often devastating impact on human and animal health, especially the heart and digestive system. We've also delved into the critical importance of early diagnosis and screening, the existing treatments like benznidazole and nifurtimox and their significant limitations and side effects, and the wide array of prevention strategies being employed, from improving basic housing to insecticide spraying to those cutting-edge biological controls.
Indeed, and we've also touched on the ongoing hopeful research. That includes the intense effort to develop entirely new, safer, and more effective drugs. The long-term goal, however challenging, of a vaccine and innovative diagnostic tools like the multi-cruci assay that could really change the landscape of Chagas management and follow-up. Despite the significant challenges posed by this truly neglected tropical disease, it's clear that global efforts in surveillance, control programs, improving treatment access, and fundamental research are making crucial progress step by painstaking step.
If we connect this to the bigger picture for you, our listener, the story of Chagas disease really underscores the profound importance of global awareness, especially with increasing human migration patterns bringing the disease to new areas, and remembering the disease's insidious, silent nature. Understanding the risk factors like having lived in an endemic area and being vigilant, as well as communicating openly with your healthcare providers if you have concerns or fit those risk categories, are absolutely vital. Don't assume it can't affect you just because you live outside Latin America now. The story of Chagas disease isn't just about a parasite and a bug. It's a profound reminder of how deeply interconnected our health is with our environment, our housing, our food, our mobility, and perhaps most importantly, our collective commitment, or lack thereof, to addressing these so-called neglected diseases that disproportionately affect the poor and vulnerable. So here's a final thought to leave you with. What role do you think global interconnectedness, things like travel, migration, and maybe even climate change affecting vector ranges, will play in the future of Chagas? Will it accelerate its control through shared knowledge and resources, or will it further expand its reach into new territories? Something to consider.